So first, thank you for joining us for this panel. I know it's pre-lunch, and there's quite a few people not in the room, so we're going to have to make this so exciting and so compelling and so legendary that it feels like a divine experience. So when you leave this panel, you tell them, man, you missed out. It was so good. It was so, exactly. Thank you. That's the kind of energy we need. As you know, we're talking a little bit about how do we, and this feels, I think, both very urgent and very important given the events in the world today, but how do we sustainably invest in innovation and equity in healthcare? How do we ensure that the tools we have reach the people who need them the most? How do we ensure that we're building systems that are effective and sustainable and frankly, locally owned? And how do we ensure that we're doing that quickly and not having a lot of conversations about it? And so we brought, I would argue, the single best panel to talk about this because they're all doing it and have been doing it before it became headlines in the New York Times. So I'm going to start with you, Dr. Amr. I really want us to talk about innovation grounded in context. You are a health leader in Egypt. You've been doing this for years. You know intimately what it looks like to build a healthcare company in a complex ecosystem, how to navigate infrastructure gaps, how to look at cost pressures, health inequities. What's one lesson from Egypt's health system that more global investors or policymakers need to understand?
Thank you very much for having us. And the main thing is, how do we use technology into healthcare systems? There's been a lot of talk about technology, about AI, and I think one of the major things which need to understand, this is the experience we have. It is a means to solving a problem. It is a means to accelerating and scaling. So this is the main thing, and I'd stress on the word you used, which is local. It needs to be cost-effective, locally developed, and tailorable, because these are new systems, these are new markets. We're not doing something where people who had access and, we're adding a lot of people. So the markets are changing, the markets are dynamic. You have to have operations and softwares which allow that to happen. You have to have the technology which is agile enough to allow that, accommodate that. So the main thing is, how do you approach? Because with investors and with global leaders, they think if it's not technology-based, the main thing is technology. You use tech and then your valuation goes up. People think valuation. Use tech, then you're more attractive. And now it was tech years ago, now it's AI. It's extremely important. I'm not saying it's not. This is what has enabled us to process millions and millions of claims. We have now more than 10 offices in less than 3-4 years with more than 500 employees doing record amount of transactions. That would not have been able without technology. But locally developed, agile, tailorable, very secure technology, which allows streamlining, standardization, and scaling of operations, because this is what is needed in really large markets, with data collection to allow more informed decision-making. And I'm a big fan of design thinking, so the idea to have that, you need to always keep on iterating, but you iterate with the right tools. So this is one major thing which we need to explain to our investors, policymakers. I would add that everyone needs to understand this is a very important safety net. Large healthcare systems are an important safety net. Policymakers need to understand that, and investors need to understand that. It needs more patience. It's a different kind of investment. It's not as simple. It's very complex, a lot of stakeholders which all need to be at the table.
Excellent. So now I have a trick question for you. What is one innovation or technology or local product that you have been impressed by its effectiveness and you cannot pick any of your own?
So it's not technology, it was the people. So what we were amazed with when we went to inside Cairo and out of Cairo in different governance is the quality and the abundance of talent and the commitment of talent. And we had nothing to do with that. They were there, and they were very talented, very committed, wanted to work. We have this term in Egypt which is ekul aish, eat bread, because they're college graduates, and they're very committed. They want jobs and different things. And this was, I found, most impressive, because the rest you can sort of solve, but if you don't have people, then there's nothing to build on.
Excellent. I also like how you sidestepped answering my question. Don, as CEO of the Skoll Foundation, you've supported health solutions globally and have done incredible work in really supporting local entrepreneurs, local systems. What's one innovation or model that you've seen that shifts systems, not just symptoms, and how did it gain traction? And most importantly, how did it attract funding?
So first of all, I'm going to suck up a little to my board member, Raj Punjabi, in my answer, because I think the most impressive thing we've been involved with is the community health worker movement in Africa, which Raj was one of the pioneers. He now works at Pioneer, but was one of the pioneers of when he started Last Mile Health. This is one of those innovations that's so obvious when you think about it, but that wasn't happening. It wasn't happening at scale. In Africa, there's a huge shortage of nurses and doctors, and we'd love to solve that, but that's going to be a long-term journey. So immediately, who are the frontline healthcare deliverers? They're community health workers. Many of them were volunteers. They were people in the neighborhood. They weren't adequately trained. They didn't get equipment, and they weren't paid. 75% were women, 80% were unpaid. I might have those numbers backwards, but they're close enough. Through organizations that started with groups like Last Mile Health and Living Goods and others, they realized that this was an incredible resource that, if trained well, equipped, and paid, could become the frontline healthcare workers. This became so clear during Ebola and then during COVID. These were the people on the front lines still delivering healthcare and going into these communities, and they're also the trusted community members who people will trust to come in to convince them to either get a vaccine or to isolate or whatever it may be. What's been so impressive over the last few years is they've built a movement with both organizations like Chic and Africa Frontline First to help make sure that we can scale this, and Global Fund is now supporting it. So for those of you who follow health funding, so much funding is siloed by disease, yet to deliver anything in healthcare, you need those frontline systems and workers to deliver it. Global Fund, Peter Sands realized this, partnered with us on something called, or they really created it, Africa Frontline First, but to get 10 African countries to agree to pay, equip, train, and integrate these community healthcare workers into their overall system. It's now scaling. There's been way over $1 billion of philanthropy and billions of dollars of government resources, both from national governments and multilaterals, now supporting this movement. And in an era where health spending is going down globally, particularly with the cutbacks in the US, but around the world, there's no more effective investment than investing in these community health care workers who are going to be there no matter what.
I think we always would say that a community health care worker is basically your local hospital in one, right? They're doing, they're giving malaria vaccines on Monday, their nutrition on Tuesday, they're helping you birth a baby on Wednesday. But one of the things that we've noticed is the greater that the investment goes into, you had mentioned specifically the percentage of women who are community healthcare workers, who are, to your point, either underpaid or not paid at all. Once they do start getting paid, the dynamic changes, and a lot of men start taking those roles. And so, yeah, once there's money, the men come. We could have a whole other panel about that.
We could do that one.
But my point here was, how do you address those deep systemic inequities while also shifting systems, right? Like, how do you make sure that your investments, you also mentioned the siloing of health funding. It has, in effect, created parallel health infrastructure that is completely almost private compared to the publicly owned. So how do we address the urgent diseases, the urgent needs, while also helping rebuild these systems from the ground up?
You built two questions in there, and I could be like my
You're
friend
welcome.
and avoid both of them. But first of all, one of the great things about the community healthcare worker, nothing about us without us is the motto of the movement. So the women who've largely organized this movement are at the front lines of pushing back. And, our job is to support them in their efforts to make this movement about them and to give them control. And I think that's the answer to your first question. I was a U.S. ambassador in South Africa where we had the largest PEPFAR program of any country in the world that had built a parallel healthcare system because at the time, President Mbeki didn't want to work with the U.S. government on PEPFAR. I was not there when this was happening, but a whole bunch of NGOs were created, and we built, incredible organizations that were providing services around HIV/AIDS and tuberculosis, but it was parallel to the primary healthcare system that was created in South Africa. Let me tell you, in the world we're moving into, if we don't break down all of those silos and reimagine what healthcare looks like broadly, because we're not going to have the same level of resources, this is going to be a huge challenge. We tried to do it when I was ambassador, and the level of we succeeded to some degree, but the level of resistance to doing this is very hard, and hopefully this, we can take advantage of this crisis to rethink how we do this stuff and make it a seamless system.
Excellent. Going to somebody who is on the front lines of shifting that system, Geeta, you are the Chief Impact Investment Officer at WHO Foundation, but you bring to that over nearly 2 decades of kind of pioneering experience in this space. And given that you've helped shape some of these massive health-focused investment funds, what is one way, and I'm going to double up my questions because I've learned it's an effective way to get answers, but what is one way where you think we can actually do that, re-envision a healthcare system that can be effectively financed? And then what's one financial mechanism, catalytic capital or blended finance, that you think needs to be used more in scaling that system?
So I think even before we get to scaling, you need to be able to have financing to be able to support the development of these solutions. And we have funding challenges across the entire life cycle. So the starting point for me, blended finance, if you look at even Convergence's numbers, in 2023, they estimated only about 3% of blended finance was going into health. Only about 3%. And some of this conversation is going to link to a panel that I was moderating yesterday in terms of the cost of capital. And so when we look at this, especially as we look at these global growth markets, we are hit with 3 realities which are very difficult for funders to get over. And this ultimately comes down the pike as a lot of pressure on entrepreneurs. The first of which is the cost of capital and the risk premium associated with this. You put this into the healthcare space and it's even further enunciating the disproportionality of what you're expecting these businesses to do and perform in a time frame which is really not sensible. So that is one thing. The second thing is that time frame piece, and I want to just double click on that. When you start looking at investing in healthcare businesses, it takes time. Because very often, and you look at India as an example, 80% of healthcare is estimated to come from the private sector, 80%. So you often have more than a dual system that is existing. And so where you are trying to have some degree of market failure, if you're using a sort of a classic economic approach that is being accounted for through the investment process, you have a complete mismatch of how capital is being allocated relative to the amount of time needed to try and build some level of systemic sustainability to be able to generate interoperability between how these businesses are performing so that you have a diagnostic solution which is leading to some sort of treatment solution as opposed to marooning people on islands of information with which they can do not very much thereafter. The third issue is the ability to pay. And we've had, even if you look at the Sustainable Development Goals, we've had this movement to getting universal health coverage in place. And there have been plenty of examples of investments that I've been working on, and others have as well, where we've been able to see funding solutions come in through some degree of public-private partnerships. It is not enough, because the bulk of funding of healthcare needs is still done out of pocket. And that is as true in low-income communities as it is in high-income communities. And so with these three elements in place, the challenges really are around how do you address that in a more systemic way, and who can do that? Because you don't have very many organizations who have the bandwidth and who have the ability to play across multiple levels of engagement like this. And so it feels like the models that we have in place are incredibly outdated. The amount of time it takes to raise funding, whether you're an entrepreneur, whether you're a fund manager, is extremely long. And capital alone does not actually equate to equity. So who is getting this funding is a huge problem. And who is on the decision-making bodies in terms of how this capital is being allocated significantly matters. So there is a lot here that I think needs to be adjusted. So if I think about one thing that needs to change, an easy answer to give you, Ala, is to say blended finance is a solution. It is a solution, but I think independent of addressing things like the deep inequity associated with the cost of capital is just going to mean that we are still swimming against the tide.
So I know you've done a lot of work, particularly on ensuring that all founders, all companies, et cetera, can have access to capital, particularly in the area of women's health, which is one that I find the vast difference in investment to be startling, because I think it's something less than 4% of investment goes into women's health, and when you discount cancer, it's less than 2%. And given the very unique medical realities for women and the very unique cost of those, it's a really surprising data point. So how do you, and I'm going to turn to our other panelists on this as well, because I know you've been on the other side of it, but how do you, in the space in which you operate now, where you're helping shape these financial systems, how do you really look at some of those underserved, not often seen, not often engaged founders or issues?
I think the first thing is you need to see who are making the decisions on investment committees. So I chair the investment committee of a Gender Lens Fund of Funds in Africa. And this argument of there aren't enough things to invest in is complete nonsense. It is complete nonsense. And so the ability to remove some of our blinkers means we need to be able to tap into communities that otherwise wouldn't be tapped into. On the investment side, less than about 7% of those working in investment firms globally are women. And capital still is going to, maybe if we're lucky, 3% of the capital is going to women founders. And that number isn't increasing. We're talking about it more. So it gives the illusion that there is a change, but there isn't a change in terms of the quantum of funding going into women entrepreneurs. And so there's this fantastic piece of work that was done by the IFC and Rock Creek Group about, it's been almost 10 years ago now. And they looked at 650 fund managers across the world. And they found that where women were 30% or more of the investment team, in the top quartile, these funds outperformed by 22% on a net IRR basis. In the bottom quartile, they outperformed by 50%. These funds actually invested in twice as many women entrepreneurs, and valuations were higher. And on top of that, there was a lower beta risk associated with these investments as well. There was a lower failure rate. So we've got the statistics, we've got the data. How do we get more money going into businesses which are addressing women's health? You need more women who are finding the deals, and you need more women on the investment committee, because that is the point, that's the point of leverage to put your finger and make a change. Which also means that we need more women sitting on investment committees, even in their independent capacities. So, and you're with 500 startups as well. So you know the importance of having this sort of structural adjustment in the investment flow. And you're going to be talking about the great work that you're doing in terms of women's health. One of the things, if we have time, I'd love to come back to is what I think is the collision course we are on currently, and the significant lack of preparedness we have for facing what is happening in terms of providing adequate care for healthy aging.
We'll make time, because I like that question. Sorry? Well, I was actually going to suggest for the Sharper Center that you should think about a workshop or something where we can actually have Geeta teach a lot of, because I think this is completely, I'm not following the script, but we'll get back to the panel in a second. I know, Don, I'm sorry, I'm trying my best, you know what I mean? Like we put the prep in. But I do think part of the challenge has been for so many people, there is this sense that the data is there. And so it's kind of common sense. You would follow it, right? And yet it's such a huge barrier to entry for a lot of people. And so how do you overcome the barrier of entry, and how do women that are already in the space, and frankly men in the space who recognize the need for more representative investment committees, more representative teams, really create the opportunity for others? I think that's a much longer conversation, but a really important one. I will say it mirrors a lot global security. If 90% of peace processes fail within 5 years, and they take a very long time to make. But when you have a more representative group, particularly women, at the agenda setting phase, they're 35 times more likely to last 15 years. And if you just think about that economically, the opportunity in that 15 years to build education systems, healthcare systems, economic growth, and markets, et cetera, is really incredible. And so it reminds me of this, in that the more representative you have that decision-making body, the more sustainable the investments and the approaches. I am going to turn now to Reedy. You have founded Next Gen Jane, an incredible company in a space that has been long overlooked, reproductive health. What is one myth or bias, just picking up on Geeta's point, that you've had to fight against in really bringing femtech to market and bringing investors to femtech?
First, I would just like to say, Geeta and Alla have just taken me to church, because I keep finding myself saying amen, especially when she emphasized that the discourse is changing, but the funding's not, and that part. So just follow that. When there's a lot of talk about we have to do something about it. Are the dollars shifting? That's really important. I run a company called Next Gen Jane. What we have developed is a non-invasive way to provide molecular insight to women about diseases that they could be experiencing. We have developed a system where they mail in their tampons, and we look at the natural biopsy that is menstruation, right? Uterine lining that is shed naturally. We sequence it, and we develop classifiers, genomic classifiers, to identify diseases like endometriosis. So this is what we've been working on for a long time. And I would say the bias that comes up consistently that's worth pointing out is a conceit that I think we have in innovation that is implicit, and I would love to make it explicit. And it is that you start off in innovation and innovating for a small, cohesive, homogeneous, and generally rich cohort. And then over time, that becomes broadly applicable, hopefully affordable, and that's how innovation, gets to the rest of us, right? And this is pervasive, whether it's in iPhones, whether it's in state-of-the-art drug development, or whether it is in massive data centers. This is how we think about the world in innovation. And my favorite example is drug development. So you start off drug development, you're doing these experiments in male-only animal models, usually. You then take the drug that you're developing into clinical trials, which are predominantly tested on men. You develop dosing protocols based on male bodies. You take it out into the wild, and you see surprising, unexpected events in women. Shouldn't be unexpected if you didn't test it in that population, right? We see this with Ambien, overdosed for women. We see this in COVID vaccine. There were surprising side effects in women that were not observed in the clinical trial. And you see this, these aren't just one-off cute examples. 8 out of the 10 drugs that were pulled off the market between 1997 and 2001 had worse side effects in women than men. This is at scale, you see this impact, right? And I think that the core conceit we go back to is that we're designing for a small, cohesive, coherent, rich cohort, and then hoping it works for the rest of us. And so I think if that is the conceit, and if we agree that that's the conceit, if someone walks into your office like I do and say, well, I'm actually designing for someone else, I'm designing for someone else entirely, people are confused. They actually don't know what to do with you. I've been told so many times early on in the journey by venture capitalists, you should go to philanthropy. Why would I go to philanthropy first? I'm developing an esoteric genomic assay for over half the population. I don't think that quite fits in the remit of philanthropy, right? And so I would say that's probably the biggest bias and impediment.
Okay, but how do we overcome that? Because I hear Geeta's point, we need more women in those decision-making spaces. Yes, the conversations are happening, the money's not changing. How do we actually now, in this moment, without thinking about the 6-step process of getting people in those spaces, women in those spaces, how are you overcoming that? And what is your biggest, as you've had to bring, I'm guessing, funders along on this journey with you, what have you noticed actually work in getting them to understand that this is actually a pretty huge part of their market, that they actually do need to invest differently here?
The easy answer, and easy in quotes, is you just pitch to enough people till you find somebody who actually doesn't have that bias. But that just means if you're pitching normally, you're thinking about 150 investors, you're going to way more, right? And you're just trying to be quicker and saying that no, clearly this person's not interested, glazed over, they're not going to get it. The sort of more fun answer is it's going to be either the carrot or the stick, right? The carrot is that we'll all reflect on this and rely on our better natures and say, here's how we should make these investment decisions. The stick is that we are all facing tied consequences because we are an ecosystem that cannot avoid the consequences of our decisions, right? If you think about like climate, right? There is no bunker or spaceship that's going to take you out of this planet or, put you underground that could save you from climate events. If your human food chain is compromised because there's heavy metals or PFAS, forever chemicals in your soil and your water supply, you're as screwed as the rest of us. Right, and so there is these tied ways that we're all stakeholders in the same community, and there are ways that everyone's going to start facing consequences and already are that I think are going to wake people up to this fact.
Can I just tell one?
Yeah, jump on in.
So we were approached by a fund investing in healthcare for women, and they approached us as philanthropy. And we thought, oh, this is really interesting, great opportunity to serve them. We took it to our investment advisors, who Capricorn is a related fund. They looked at it and said, wow, there's so much alpha in this because no one else is doing this. Our returns, this is not concessionary. We can make a ton of money by investing in this and do good at the same time. So I do think starting to reframe the argument and saying, hey, here's a space that no one else is in, and you can take advantage of it if you can find the right audience is helpful.
I second that. There's this interesting leading kind of funder from Asia had talked about the correlation they see with books. It was actually very interesting. He said, listen, back in the day, people tried to market books to men, and then they realized 75% of people who purchase books are women. And suddenly you saw complete industries get way more funding, the romance section of and it was interesting to hear that framing of like, if you actually make it a dollar argument, I think it heavily is oversimplified because I think a lot of women founders and investors can make a very strong financial argument. I definitely think there are biases and things there, but I also think part of it is, can we articulate that without investing in this, you lose out on a much bigger market share in a really compelling way? I'm going to jump now. We're going to come back to this. I love where this is going, by the way. I did not orchestrate this. This was not meant to be a gender investment conversation, but I'm glad it is. But I am going to jump to Raj because we've mentioned COVID. We've mentioned kind of all of and Dawn mentioned some of the recent shifts in funding for health. There have been so many, I would say, crisis points. You've worked at the intersection of last mile, you've worked at innovation, you've worked on pandemic preparedness, you've worked in investment, you've worked in biotech. As we think of everything that's happening, how do we bake resilience and sustainability and preparedness into our long-term investments?
Can you hear me? Good. Well, yeah, so I'm the son of a woman who's a scientist and a father who's an entrepreneur. So it wouldn't be surprising that I would learn from their perspectives. And what I've learned, especially about crisis, is that there are three outcomes in a world that has multiple crises happening at once that we often think of. One is that crisis can make us weaker. Another is that after the crisis, we can wish to go back to where we were before the crisis. The third outcome is to get stronger through the crisis. And that is where a scientific mindset and an entrepreneurial mindset matters, because it is entrepreneurs that I've seen again and again able to focus during crises on getting stronger through the crisis. How do you get less fragile when things are on the other side? And I think that mindset's really important no matter what sector you're working in today, social, public, private, or the mix of all of them. We at Flagship Pioneering, and you heard my colleague and friend Nubar Afian, some of you did yesterday at the keynote, speak about, in part, the way we approach entrepreneurship and innovation at Flagship. And what's key to know is that we're focused on working with scientists, entrepreneurs, and creating companies that benefit human and planetary health. I got brought on after the COVID crisis, working on it at the National Security Council here in the United States, to ask the question, could we become, as we tried to be during infectious disease crises, more proactive and less reactive? Could we do that in public health and in population health in general? And that really deeply resonated with me, because as a doctor, what I saw, and I think many of you could relate to this, if I were to ask you to think about someone in your life, a loved one perhaps, that has faced a devastating diagnosis. I imagine you might think about, as I saw often in clinic, that other than fearing losing your life from, say, cancer, you might actually fear the loss of control over your life just as much. And whether I was in the clinic or in the White House Situation Room working with patients and crises in their lives or public health crises, that was a theme throughout. So Flagship decided to take on this idea of preemptive health and medicine. Could we restore control to patients and the people closest to them? Could we empower them to be more proactive about their health? Could we improve, maintain, and protect their health before they get sick? How do we do that? Well, in part, it's by creating innovations that allow you to test for cancer at its earliest stages, just like we do for cholesterol testing today. So we have a company called Harbinger Health that's focused on globally making cancer screening as affordable and accessible as cholesterol blood screening is today, so that we can arrest cancer before it threatens our lives. We just released another company this morning, or unveiled it, called Etiome, that is focused on developing medicines using an AI platform to detect diseases like Alzheimer's or obesity-related diseases, metabolic diseases, at their earliest stages, and developing medicines for those earliest stages so that we never experience symptoms, we never experience pain that can control our lives. So to me, when we talk about resilience, the scientific mindset's critical, the entrepreneurial mindset is critical, and when we harness that, we can build resilience in the lives of patients and those who may fall sick by restoring agency and power to them.
I love that. I'm going to plug immigrants here because why not? But I think
we get the job done.
Yeah, we get the job done. I think that mindset is actually, because my dad always used to say, the only way through is through. What else are you going to do? And I quite like that because I think it sums up that mindset perfectly. I was at the World Bank spring meetings in DC yesterday, where they're talking about AI, basically, and job creation. But AI kept coming up as it does. But the number one word that was anchored around it was agency. Yeah. Was that a lot of people feel as though technology is happening to them, not for them, not with them, and that it's the lack of agency, a sense that you are no longer in control. And so to hear you say that for health sciences as well, this notion of that's actually what we're trying to give people, is a sense of agency and power, I think is really powerful. I'm going to pivot to Teddy, because Teddy, we've talked a little bit about, or quite a bit, about crisis, underserved populations, and you are at the forefront. You are leading in Ghana, really cutting edge work, and we've, I think, understandably recognized the importance of solutions that can work and scale in Africa. Tell me a little bit about your work and what you've seen and what's really excited you about the potential.
Well, thank you. The thing is, neurosurgery has got a bad name because of primary healthcare, right? Tomorrow is World Malaria Day, right? And 90% of the mortality due to malaria is happening in Africa, right? So when people talk about impact, the last thing they talk about is specialized surgery, right? But the truth is, the interventions you can make for malaria are basic interventions, right? And changing environment and, things that you can put in, like vaccines, like drugs and things like that. But the thing is, for young people, the top killers in Ghana, where I work, and the things that will happen and guarantee mortality are traumatic brain injury and hemorrhagic stroke, right? And there's nothing you can do about that apart from trained people who can deal with that crisis, right? And that's where the problem is, because Ghana is 36 million people with 27 neurosurgeons, right? And that is the problem. How do we, pivot our systems so that we can train people who can handle this crisis? It's not a dramatic crisis, right? But the thing is, I've got a young girl, 15-year-old sickle cell patient, right? The parents have been dealing with this disease all their lives. And then one day she bleeds. Then we do a CT scan, and she's got a blister on a blood vessel. Now, she's bled once. If she bleeds again, that's it, right? Now, it just happens that there was a collaboration that allowed a team of surgeons to get together and clip that aneurysm for her, right? Now, so what I have seen in my practice so far is the fact that we have governments which are oriented to the treatment of primary healthcare problems, right? And so they fund the treatment of primary healthcare problems. But the thing is, the pathologies that guarantee, mortality are put in the luxury department and are not looked at. But the rest of the world is aging. We've talked about Africa and its median age. It's just, 17. Ghana is 21 median age. Denmark is going to be 70 median age in 50 years. Africa will be 31 still. So the rest of the world is aging, faster than Africa. And any interventions we make into young people and guaranteeing that they are functional is actually, investing into the future for the world. Right? So I think that, there's the crisis of not training enough people to deal with the mortality problems. But there's also, the planning that we must do and look at this problem as something that, we have to basically invest in to protect our future as the world.
Thank you. So I'm very bad at timekeeping, but I'm going to turn to Teddy, Amar, and Raj because the three of you have been practitioners on the front lines in Africa, and we've talked a little bit about the demographics. By 2050, 1 in every 2 jobs in the world will be an African job. So to your point about the necessity, the economic necessity of investing, but it does feel similar to Geeta's point on investing in gender. It feels like we talk about it a lot, but not much has changed substantially. And so what will it take, in your perspectives, to elevate African practitioners, not just as providers, but as global health architects, experts, finance? What do we need to do differently that we're not doing? And feel free, whoever wants to kick off.
Okay, so this is very important because when we talk about healthcare systems, and this is, I think, what Teddy was saying, and there are different levels of it. You need to think of it from a more global perspective and have an overview. So that overview, primary care, and then secondary care, and then tertiary specialized care, and then who is paying for it, and all the different stakeholders. And then we start forgetting that, are we teaching doctors and nurses health economics? Are we teaching them healthcare management? Are we teaching them informatics? Are we going down to which level? Who should know what? So societal buy-in is very important. Are we teaching at schools the importance of a relation that when in healthcare systems we're looking at societies, not at individuals? So one very important thing is education of people who are going to be providing the service or involved into it. Not just doctors, not just nurses, but of course the emphasis on them. This would shift, it would take time. It's a long-term investment, and all healthcare is a long-term investment.
I like that. So doctors taking over. Okay, noted. Teddy?
I think it's special for Ghana. I teach in a private medical school, which is now called a girls' school because 75% medical students are ladies, right? Ghana is a country that has almost 60% of its entrepreneurs being ladies, right? So I think ultimately I look at the education piece and see that it is growing. There was something that we grew up with when it was called send your girl or child to school. And sometimes we worry that boy child is being left behind, you know. But the thing is, education, yes, being pushed along, and then also the agency that you talked about in, you know, empowering entrepreneurship in our environment, microcredit systems for entrepreneurs who are ladies, so that, because once you guarantee good income for the woman entrepreneur, her children are taken care of. And ultimately, if we really wanted primary health care to survive, and therefore secondary and tertiary health care, then we should make sure that the children are well taken care of.
Raj?
Yeah, just to build on that, what I keep hearing, and a number of our colleagues at Flagship Pioneering keep hearing from countries about, is the desire for their scientists to be able to file for intellectual property, to be able to create companies in their own regions, to be able to create something that can impact their own communities, but also creates economic value for their own countries. And the reason that is felt even more urgently now after the COVID-19 pandemic in places like where I grew up in Liberia is because many countries, whether you were low income, low middle income, upper middle income, or even upper income in many cases, were stunned when they realized that they had to wait for vaccines developed somewhere else to be delivered into their own countries. And so one might look at that vaccine inequity and ignore it. I don't think anyone here would try to do that. Another way to look at that vaccine inequity is to say, well, all the rich countries or all the rich companies in the rich countries need to just give away the vaccines. There's a role for manufacturing vaccines and ensuring that they're filled and finished, as we like to say, in places like South Africa or Kenya. But that is not the ultimate dream of a scientist who would like to take his or her own vaccine idea and be able to create a company in their own country, whether you're in the Middle East, you're in Southeast Asia, you're in Latin America, you're in Sub-Saharan Africa. You want to be able to take a malaria vaccine, for instance, and create the insight, the company based off your scientific insight. If you're at the University of Ghana, and you should deserve the capital to be able to do that. You deserve the legal managerial support to create a company out of that. And you deserve to help your country create economic security based on that. But that's not the way the world's designed today. And we need to be able to get there. And I think if we can do that, if we can move from just shipping vaccines, for instance, to countries, to being able to create the technology to develop those vaccines, then that's very possible. And some may say, well, look, that sounds pretty like a rosy colored view of the world. It's not possible in a continent like in parts of Sub-Saharan Africa. I would challenge you because, to your point, we have some of the best talent in the world, some of the youngest, most entrepreneurial talent, some of the most resilient talent. But on top of that, you have a free trade agreement, the Africa Continental Free Trade Agreement, that's going to help make a common market and perhaps create one of the world's biggest growth opportunities in history in the next few years to decades. And then on the medicine side, you have the Africa Medicines Agency, which I know at the Skoll Foundation, we've been very happy to support the African Union in helping build the capacity of institutions like that. What is that going to do? It's going to create the regulatory apparatus across a common market to be able to have a scientist in one country be able to get investment capital and create a company that might produce the next Ebola test or the next influenza test and the next influenza treatment or the next cancer drug that one day we may be importing here in the United States.
So what I'm hearing from the three of you is really at the individual or kind of the practitioner level, more agency, more investment, and at the enabling ecosystem level, more infrastructure, financing, regulatory support to actually be able to drive some of those innovations or some of those systems to fruition and to market. So I like where we're anchoring there. This notion of investment alone is not the answer. It has to be met with both agency and support at the individual or practitioner community level, and it has to be met with regulatory and policy support. I'm going to open up questions to the audience. And we are, this is the best panel of the conference, so make sure the questions are really good. You know what I mean? We've got a bar to keep up, right? Please introduce yourself when you ask your question.
Oh, thank you. Good afternoon. My name is... I was trying to make sure that the timing is correct. Okay. Good afternoon. My name is Shiko. I am not medicine anything, but I have high interest in medicine. So I was listening this keenly. I think we've spoken with Geta about fundraising as a woman. That is a whole topic by itself. However, I want to double down on what you talked about, the health space. So I hear you speaking about importing drugs and stuff, but right now, some of the IP in the health space is actually African, right? So University of Cape Town, for example, produced a malaria vaccine, and I think this week, I think on Monday or last week, Friday, they also released our HIV vaccine. Yeah, Cameron, Kenya has also been working on this. I hear you saying that we need to flip the model. Do you have that action point of how do we flip the model? How do we already have this, how do we scale? Because Africa is not running out of ideas. We produce great ideas. We have great IPs sitting in our universities. The challenge we have is being able to commercialize at scale. And I feel like, calling SCOL and other philanthropy fund partners is how do we then move these great ideas and great concepts and great IP to scale? Because this idea of University of Cape Town has produced malaria vaccine and HIV or KEMRI will sit down quietly for another 2 to 3 years, and then you'll hear a lab in the US has done the same exact thing using the same IP and gotten billions of dollars in investment.
Excellent. So question number 1, how do we commercialize at scale? I'm going to take a couple more before coming back to the panel. Dina.
Hi, everyone. My name is Dina. So nice to meet all of you. I really want to bring the conversation a little bit back to women. So I have 2 quick questions. One, to Gita and to Rita, you were saying we need more women to be investors. What do we need to do to make that happen? Because I feel like I've been hearing this for a very long time. But also in hearing the conversation, I feel like we need more doctors to be entrepreneurs too. So how do we get more women to be investors so that we can see a lot more gender equity enter the healthcare space? But then how do we get doctors to also take the leap and also become entrepreneurs? I don't know, I'll leave you guys to decide who wants to answer. An excellent panel. I don't want to say it's the best of the, but it's
the best, Dina.
Excellent panel.
I understand you don't want to pick a favorite child, but we know who it is. But behind you, hand up. I can't, the person with their hand up.
Hello, excellent panel. That's the excellent. So yesterday, Norbert, pioneering flag, he spoke about the speed of discovering vaccines. Right now, we showed us a chart with long then history, a blip in history, and knowing, understanding DNA and information system. My question is about now that the paradigm and speed changed in the way we access information with AI, will that impact the speed, the African access to healthcare in developing drugs and vaccines, given the speed and now the focus on human ingenuity instead of capital, because now time is not an issue. Also, the KPIs of investment in healthcare. Now that you talk about gender perception and philanthropy, when you pitch healthcare niche oriented to women. Now, if we talk about drugs with data in Africa, how will investors look at that in terms of KPIs and market size and ethnicities?
Great. And I'm going to take one more question and then come back to the panel. Right up here. Yeah.
Thank you so much. I'll be very quick in this. This panel, well, the best, yes, but again, I think very appropriate at this time. Oh, sorry. No, it's
you don't need to tell me. I know. Don't worry about it. I got you.
Oh, God. Modesty out of the window. Yeah, I think I'm just saying it's really appropriate at this time where we've seen a reduction of sort of, I mean, a lot of our health system dependent a lot on foreign aid, and we know what has happened to the ID and all of this stuff. So I think a couple of things. One is that I'm seeing innovation, I'm seeing the point of rewiring. So in this very context of resource scarcity, if you're talking to an African government, where do you start when you want to lean on innovators and entrepreneurs? That's one. Two, there's definitely a history of disinvestment in the health sector, right? Especially not generally everywhere, but on the lower levels of the health sector. So if you come into a continent, it's very much level 1 hospital. Where to the women question, a lot of nurses are the ones that bear the burden of the health system. So again, how do you also help that particular tier of nurses, especially around task shifting? And nurses open the clinic, are the ones who clean the clinic, are the ones who will do the triage. So again, to the gender question, where do you start?
Excellent. So I'm going to ask the panel as a whole to jump in on the questions that they feel resonate most with them. I'm going to give us about 10 minutes. So please solve how do we scale? 7 minutes, my bad. So solve how we scale, how we get more women in investment, how we get more physicians and healthcare practitioners to become entrepreneurs, where African governments lean in, how we support nurses and midwives, and how we ensure that we're equitably investing given or how we reconfigure how we invest and how we find entrepreneurs given AI and the speed with which AI is moving. Teddy.
Well, I'll have to run, but I just need to say this. Well, I think that when it comes to how do we start it, how do we become entrepreneurs, we just have to start it. It's courage that takes it, and we just have to identify a problem and try to solve it. And I've heard on this panel different things about, looking out for all the, pitfalls and all that. Ultimately, to become entrepreneurial, we just have to start. And I'll just say on the policy side, we must think about centers of excellence when it comes to, training these nurses or training these doctors. It is no longer practical to make primary health centers become capable of dealing with tertiary things. But we need to concentrate the specialists in centers of excellence so that we can make the most of their expertise, I think.
So healthcare systems are very complicated. Policy and governments have a crucial step to make. They need to create an environment so that all the stakeholders can find something to contribute. So whether it is investors, because you have different types of investors, PEs, VCs, everyone wants to invest in patient capital, impact investments. So the role of policymakers and of governments, and I would advise them very much to always look at the overview of other experiences in similar demographics. There's a lot to learn in Africa from each other, from other countries which have started to do that. And this is one of the things which I've seen firsthand. It is extremely important to set that stage, put that mindset of why the government it's not supposed to monopolize and do everything. It is supposed to create that environment and assure that there is equitable distribution of access and of quality, fairness in distribution, fairness in pricing to all the stakeholders. I can explain more about education. You have to go to education, but this is the main thing which makes a big difference.
Okay, and I'm going to target the rest of the panel on what I think are the kind of two outstanding questions: impact of AI on the decisions we make in health systems and health space and health investments, and I'm going to close it out on how we get more women as investors, because frankly, if you take anything away from this panel, it should be that. Who would like to kick us off on impact of AI?
Yeah, I'm happy to do that. Just like with other innovation is not innovation if it excludes those who need it most. And some of the places where AI innovation could make the biggest difference are in these settings. At Flagship, I've mentioned how we've tried to do that with a couple of examples already. Let me give you another example from the social sector. Last Mile Health, which Don brought up earlier, that I had the privilege of co-founding many years ago, has been asked by the Ethiopian government to create an AI-empowered call center so that its network of 40,000 women community health workers, so-called health extension workers, who deliver healthcare to nearly 100 million rural people, can have a better response time, a more effective response when there's an emergency. Say a woman comes to the clinic or health post and needs a C-section, or someone breaks a limb, or someone has a heart attack, and so that an ambulance can get out there more quickly and they can be triaged more quickly. That is the kind of innovation that allows us to take what has always been the highest standard of care, not just high-tech healthcare, but high-touch healthcare, and supercharge it to another level. But it comes back to a point you made earlier, which is that people in the countries, those closest to the patient, closest to the problem, often are closest to the solution if they get to help not just receive the solution, but actually drive the design of the solution. It's not innovation for people, it's innovation with people. It's not entrepreneurship that benefits people, it's working with people to become entrepreneurs. That's what's critical, I think, in making sure AI benefits all that it could benefit in healthcare.
I just want to build on Raj's point, but put it in a little different context. Let's be real about what's about to happen in the global public health system. We are about to lose a huge percentage, who knows what it's going to be, of the funding that exists. I think in that crisis, and it will be a crisis and people's lives will be horribly impacted by it, already have been, we need to reimagine or rewire the future of health. And I think, to Raj's point, we have this opportunity now where it's not going to come out of Washington, and governments around the world, citizens around the world need to stand up and say, this is what we want our healthcare system to look like. And this is the moment to do that. And, it's going to take entrepreneurism like we've never seen before. There's a really interesting, just to come back to the AI for a second, the reason DeepSeek created a completely different model was they were constrained. Out of constraint, we see new models for how to build back better. We are, let me tell you, in global health, entering a period of constraint, and it's going to be up to all of us to reimagine what that rewiring looks like that builds in the values that Raj was talking about and we've all been talking about.
So I think, one of the things that we've been struggling with throughout the conversations we've been having over the course of these last 2 days has been also where the money is going, where the investment is actually going relative to where it's needed. And what is skewed is the fact that there are certain sectors which are capital intensive, financial services, for example. And then you have sectors which are driving things like food security, employment, agriculture, where there's very little capital actually going into this. And so when I think about AI, I wanted to just touch on that for a bit, because I'm asking that of myself on a regular basis now because I want to understand where the opportunity actually is. I started my career investing in SMEs, actually in hospitals, in diagnostic facilities, and we seem to have moved away from this discussion, assuming that early stage businesses are the same as investing in SMEs, and they're not. They really are not. We still need the brick and mortar buildings. So as I think about where these options are, what I'm keeping my eye on are solutions from an AI perspective to reduce, for example, the administrative burden within healthcare. I'm looking at where is AI coming in terms of disease diagnostics, and how is that going to be fitting into the brick and mortar solutions. A third area for me is clinical decision support. And some of the reasons I'm looking at this is because I see it touching back to the challenges we have in terms of insufficient human resources. Whilst our disease burdens are changing, they're morphing and increasing. And if we want to put agency, to your point, Raj, back in people's hands, we're going to need to do so with the ability to integrate some degree of solutions on things like our phones, but know that there are places for people to go, because not all solutions will end just through the phone. And I'd like to just touch on the point around women's health. So we have a bit of an underground network going with women investors. And there are a few organizations like the Private Equity Women's Investment Network. And you know what we do? We say we're going to create our own mechanisms to connect deals. And so that means that we have meetings. There's one conference here in the US I've been going to for a very long time, which is a women's PE conference. And we do not sit there and talk about the challenges of being a woman in this space. We go there and we say, let's do deals. And there is, when we are, as being part of this network, we have 3 things that we can ask of each other, and you cannot say no. 1, I have something that I need. 1, I have something I can give. 1, what can I do to help improve the ecosystem? And so we are trying to, at least in the meantime, hustle our way to try and get more solutions in place. At the WHO Foundation, we set up a Catalyst Fellows program because part of the issue, to your point or your question, Dina, is to remove this false assumption that investing is almost like alchemy. And it's not. It really isn't. So very often, you just need to be able to crack the door open a little bit. So we run a double-blind process on the application process. We've got our 3rd cohort right now, and we have doctors who have never invested before. So you need to be a graduate student, and what we're looking for are people who are innovative, who are interested in entrepreneurship, people who are interested in investing, and the focus for us with this program is to ensure that these are individuals who are able to often enter our program feeling like they are well-experienced investors but haven't done very much in healthcare, or they're individuals who have got a healthcare background or have an interest to go into healthcare. And by the time they leave our program, there is a understanding of how does this work within public health, how does this work within private health, and having the ability and the confidence to know that if I'm looking for funding, these are mechanisms I can go through.
I love that. I'm inviting myself to that women's conference, and where we do deals. And I also have so many names for you for potential fellows, so I'm going to send those to you. You get the last word.
Oh my gosh.
No pressure.
There's no easy solution, but I will offer up 2 comments, and maybe we can glom them together and glean some insight from it. Amongst female entrepreneurs, we know there's a trope that's backed up by some research that women get asked about how they're going to manage risk by investors, and men get asked about their vision. And it sort of speaks to the fact that when you're seeing a female entrepreneur, you're trying to manage downside risk, right? You're thinking about the downside. And when you're talking to a male entrepreneur, you're thinking about upside. And I think that's reflected in female investors as well, because the sheer volume of female investors has actually increased. I've noticed that the funds, they're all like $10, $20 million funds, right? Like LPs are also sort of writing small checks for these female investors.
Like microcredit on steroids.
It's totally. And I fundamentally and firmly believe whenever you write someone a small check, you're telling them, this is a really cute idea, try a small experiment and get this to the next level, right? Versus like if you look at male entrepreneurs, they'll get like a $50 million check. You're saying, take a swing. I want to see a home run. And so the only thing that I can offer up is that there should be a shift in risk appetite when you're thinking about female investors, and you'll see more female investors.
That's true across that's true across philanthropy. That's true across the board. Is we write smaller checks for women. First, thank you to the audience that has grown substantially since we started the panel because it was just so riveting. I'm so thrilled that you got to hear from this incredible group of people.
Look how many more people.
I know. It was because they got the message. You know what I mean? Like it's been trending. Thank you. And I didn't even have to say it. It was very organic. But really, I think if there's 3 messages you've taken away from this, the first is solutions that work start with context, community, cultural fluency, and agency, not just code or capital. Who builds and who funds and who decides is critically important, and who benefits, and must be rebalanced if we're really thinking about how health innovation and investment are going to drive real change. And while blended finance and catalytic capital and policy shifts are really crucial and exciting, it's really about shifting power and reimagining accountability and shifting agency within the health ecosystem, and that includes bringing unseen entrepreneurs and underfunded entrepreneurs and women to the investment space. But I'm really thrilled. I hope that you have all taken away something that you individually can do in this space. We all occupy spaces of power. So if you're thinking about who you're funding or who you're hearing from, or what kind of risk appetite you have, or how you're investing, or even how you're talking about opportunities in Africa and opportunities around the world and the intersection of health and innovation and investment, I hope you've taken away something from this. Thank you.
Thank you.